Welcome to the National Headache Foundation's Women in Headache webinar. This evening we're joined by Dr. Sylvia Lucas of the University of Washington Medical Center. Dr. Lucas is currently the clinical professor of neurology and rehabilitation medicine. She is also the founder and director of the UWMC Headache Clinic. Dr. Lucas, thank you for joining us this evening.
Thank you so much, and thank you everyone for giving up this valuable shopping time to join us for the webinar. What I'd like to do is take you through the objectives of the talk I'm giving tonight. I'd like everyone to be familiar with female reproductive events that can influence migraine. Be aware that many women with migraine can have hormonal triggers, especially around times of changing their estrogen levels, menstrual periods, or at ovulation time. And also be aware that sometimes it'll be great having your estrogen change. For example, about the only good thing about menopause, I can speak from experience, is significant decrease in migraine frequency and intensity after menopause. But at the time you're going through it, your headaches can be fairly unpredictable. These are my disclosures. I've been a speaker for several companies that make migraine drugs. I've done research in this area, and I've been on some advisory committees for different companies. Many of you know this, but I've always thought that this is a really fascinating slide because it shows the prevalence of migraine, how much migraine there is in the United States at any particular year. And the red columns are women, and the blue columns are men. Did I pick that well? And the prevalence is on the left, and your age range in decades is on the bottom. And you can see that there is an increase in migraine in women that goes up through your 20s. And there's kind of like this peak prevalence time. People are getting headaches mostly between their early 20s and perhaps their mid or to late 40s, and then the prevalence start going down. With men, you still have a little bit of a decrease, but it certainly isn't as pronounced. You can see it there, however, in 60s, 70s, and 80s, and this probably has to do with the fact that the receptors that we think are important for headache processing probably are not as prevalent when you're at an older age group. The interesting thing is when you look at who gets headache the fastest growing segment of the population, we call that the incidence. Boys are a little bit earlier than girls, and that's at about 8 to 10 years old, and then girls come in at about 13 when they start their periods, and then of course there's this huge disparity until what I call retirement age. So we think that this disparity, of course, has a very close relationship to hormones, specifically plasma estrogen levels. So if you think in your mind about different events that can influence migraine, then think about when in your life, and I'm using the proverbial you, when in your life that you would experience a change in hormones. Well, one is when you start your period. Two is when you have your menstrual period. And with some women, there's also a change at ovulation. Three, you could be influencing your estrogen by taking outside or artificial estrogens, such as in oral contraceptives. Four is pregnancy, when your estrogen changes very, very rapidly. 5 is menopause, when your estrogen drops to very low levels. And 6 is another artificial introduction of lower amounts of estrogen in hormone replacement therapy. So the highest incidence, as I said before, is really close to menarche. When women start their period, they're going to have the highest incidence of migraine. All women will have all women with migraine don't necessarily have a link to their menses, but if you have a relative sensitivity to the cyclic decrease in estrogen that happens just before you start your period, then you have menstrual-associated migraine. And about 60% of women who have migraine find an association between their menstrual periods and having a headache. Now, that doesn't mean you can't have headaches at other times, but there is this tight link. And also, there's a subset of these women who also tell me that they know that they will have a headache mid-cycle with ovulation as well. Now, pregnancy can be associated with an improvement in migraine, especially after the first trimester. Why is this? Because when you first get pregnant, your estrogen levels just shoot through the ceiling, and in fact, by the time you're ready to have a baby, your estrogen levels are 200 times what they are normal. But the important thing is that they're stable. Perimenopause can be associated with a worsening in the frequency, intensity, and the ability to predict when a migraine is happening. Why is this? Well, because perimenopause is not stable levels. It's not like your estrogen levels are falling consistently, because some periods might be associated with egg production, and the eggs are responsible for putting out hormones. And they may not be doing this regularly. 2/3 of postmenopausal women report an improvement in their symptoms, but that's when menopause is done, and sometimes that can take a while. It's not just stopping the period. It could be a year later. This is a really busy slide, but if you could just look at the E2 slide, what this shows is, what that purple line shows is what happens to estrogen during a woman's menstrual cycle. So if day 0 is the start of your menstrual period, your estrogen is really low because it's already dropped. So as the hormone levels go up, you see a first peak at about mid-cycle, and that drop, which is also associated with ovulation, starts leading up to a second peak at about day 23, and then you've got this dramatic and sudden drop, and that leads to your period. But that change, that rate of change, that sudden drop of the estrogen is what's thought to trigger menstrual migraine. You also can think about oral contraceptives in the same way. For women who take the birth control pill and then the week of their period are taking the fake pill or the placebo pill or the inactive pill, a lot of women will notice that a couple of days after they take their last real birth control pill that they're triggering a headache. And that's the same thing. You're noting an estrogen drop as well, but you're actually doing that by not taking active pills, but then going to inactive pills. So it's still an estrogen drop. This is from a study done looking at diaries from 55 women, and really it's just when they had migraine during the month. And that sort of underlies what we were saying, that if you ask women to put in a diary when they have their headaches, you can see here that the day of the cycle, the day 0 and the day 1, show the biggest number of attacks, headache attacks that women have. So menstrual-associated migraine is really a very difficult time in terms of having migraine. When should menstrual migraine occur? Well, it shouldn't occur anytime, but if you're looking at slides like that, you're really looking at about 2 days before to 3 days after the onset of the period, and those are days that women are likely to have this association. There is also an entity called pure menstrual migraine. These are women who only have the headaches 2 days before to 3 days after their menses. And they don't have them at any other times. But menstrual-associated migraine or menstrual-related migraine will occur then always, and then at other times as well. Why do we care about menstrual migraine? Well, one thing, it's predictable. A lot of women know when they're going to have it. In fact, I had a patient today, a new patient, who said when she starts getting a left-sided headache, she knows that she's going to have her period in 2 days. So sometimes the headaches will precede the menstrual period, and besides knowing that your period is going to come, these headaches can be slightly different than someone's usual headaches. Many women will say that they're more severe, they're longer in duration, and many physicians feel that they're more difficult to treat. I think we went over most of these, but one of the things that you can see here is they're predictable. And if they're predictable, sometimes that can allow us, and I'll talk about this a little bit more, to pre-treat, or sometimes we call this mini prevention or mini prophylaxis. The last point that I'm showing on the slides is sometimes besides having headaches, the fall in estrogen can trigger perimenstrual dysphoric disorder. This was known in the past as PMS, this perimenstrual syndrome. And so there can be other things besides your headaches. It certainly doesn't make you feel any better. A little bloating, a little depression, irritability. So again, it's this big package that the loss of estrogen really causes. So what can we do for women who have menstrual migraine? Well, many women, particularly if they have a lot of headaches, will be on preventative medications. And these are drugs that you may have heard of in the past: amitriptyline, nortriptyline, verapamil, propranolol, nadolol, Topamax, Depakote, gabapentin. These drugs are taken every day to decrease the frequency and intensity of headaches. Some people will be on these drugs every day, but they might increase their dosage. For example, if people were on nadolol 40 milligrams at night, maybe they'll bump it to 80 milligrams during this perimenstrual period. So that's one conventional strategy. Another is to either change the way women use oral contraceptives or start oral contraceptives to treat menstrual migraine. For example, if women are on oral contraceptives and they have a placebo week and have a period, what they can do is eliminate the placebo week. Just keep taking active pill to active pill. You don't have a period, and therefore you don't have a headache because you try to block that fall in estrogen. That's called continuous oral contraceptive dosing. Sometimes we'll even start women on oral contraceptives, not because they need it for birth control necessarily, but because you're trying to control the migraines. Hormone replacement therapy for women who have finished having their periods. It's important how this is dosed. In the old days, they were doing cyclic dosing. You might give a low dose of estrogen daily and then progesterone every 3 months, and that tended to cause more headaches. So if women do choose to have hormone replacement therapy, the lowest dose in a fixed dose is best. And of course, if women have not had a hysterectomy, if they still have a uterus, they need estrogen and progesterone. We are pretty much avoiding equine-derived estrogens. Now these are, we used to know these drugs with brand names of Premarin. The conjugation tended to be associated with more headaches. And equine estrogens certainly are not as popular as they used to be because of that reason, and also because some people don't like the idea that horses are used purposely and kept in confined quarters just to collect the horse urine. But at any rate, there's plenty of estrogens that are more like human estrogens that are derived from plants like soy that we use now. And of course, using the lowest dose possible is good for many reasons. One being to try to decrease the possibility of having headaches. I want to just talk about a case. So here's a 23-year-old woman. She had a history of menstrual migraine, no aura, and remember that the aura can be twinkling lights or numbness or something that you have before the headache. For most people, it's going to be twinkling lights or stars or starbursts in their vision. But her doctor started her on the birth control pill, and her headaches changed. So now she is having weakness and aura that is very, very different from her usual headaches, and she was concerned about the birth control pill. So the effect of oral contraceptives themselves might be important on the course of migraine. I mentioned oral contraceptives as a treatment, and that helps, but about 20% of the time women may get worse. And certainly if women get worse, and when they're on the lowest dose of oral contraceptives, it doesn't help to stay on the oral contraceptives and you get off. The headaches that are caused from oral contraceptives these days are less of an incidence than about 20 years ago when there was much more estrogen and progesterone in oral contraceptives. So they're pretty safe, and they usually don't cause headaches. But as you can see in this slide, 3 to 1/3% of cases got better, and about 20% to 50% got worse, and there was no change in about 40% to 65%. So those are all over the board. But I think roughly 1/3 of the time people get better, 1/3 of the time people get worse, 1/3 of the time there's been no change. So with this woman, we worried about her headaches getting worse, which they did, and for most people, it would be recommended, highly recommended, that they get off oral contraceptives. Rarely, the first migraine attack can be triggered by oral contraceptives. So if you're on the birth control pill, you start it or you change the pill, and you have a new persistent or longer headache, you have new onset aura, any visual or other neurologic symptoms, your headaches increase in number or they increase in severity, or your aura symptoms, if you already have them, are worse or longer, then you really need, this is an urgent thing that you have to talk to the doctor about, and probably 9 times out of 10, the patient's oral contraceptive would be changed, or more likely than not, discontinued. So that ends my prepared statements. I just want to go over the points that we brought up. Women's issues in migraine typically have to do with what's going on hormonally. So anytime you have a change in estrogen, whether it's increasing, like when you start having your menstrual period, when it's decreasing right before your menstrual period, when you're pregnant, your headaches can be exactly the same, but the end of pregnancy heralds this wonderful, stable, high estrogen, and women tend not to have headaches during the latter 2/3 of their pregnancies. At the same time, after menopause, you have a very low but stable level of estrogen, and so that's also a pretty good time. As you're heading into menopause, however, it can be a little bit tricky and variable, probably because menopause, which is also known as ovulatory failure, certainly isn't a nice, smooth transition, and sometimes the periods are irregular, ovulation is irregular, the estrogen that eggs produce is not the same every month. So that's usually the issue. It's sort of unpredictable levels of estrogen. And then as you finish, which can be a year, it can be 2 years after you start your perimenopausal symptoms, even longer in some women, it's very unpredictable. Things get a lot better. So that's my presentation in a nutshell, and I hope that's triggered, if you will, I hate to use that word, but some questions that you might have about the relationship between migraine and hormones, migraine and women's issues, or any other questions you might have pertaining to migraine.
All right, it looks like our first question comes from Rosalie. She says she's close to having daily chronic headaches, and since she's very sensitive to drugs, she'd like to know if you could recommend any pills that would least likely cause a reaction.
As far as your daily chronic headaches, Rosalie, it's hard for me to tell you what drugs wouldn't give you side effects because I don't know specifically which ones you've been on and which ones have given you side effects. I will say, however, that if you're at the point where you're having daily chronic headaches, you undoubtedly have seen a headache specialist. If you haven't, you need to, if you can, because these are the types of headaches that 4 to 5% of the population get. They're extremely difficult to treat, and many of them don't respond to medications. So you have the tricyclics, drugs like nortriptyline and amitriptyline, and sometimes if you have side effects on these, like sedation or dry mouth, you have to go down to kids' dosages, pediatric dosages, and many of us start with doses that are probably too big for our patients. The epilepsy-type drugs like Topamax and Depakote, those are useful too, but again, sometimes we tend to start with higher doses. Many patients are extremely sensitive to the side effects of drugs, and if you're sensitive to the side effects of drugs, it may mean that you'd be more sensitive to a lower working dose of the drug as well. So we have to start slow and move at a very slow pace for people who are extremely sensitive to the side effects of medications. If you fail these, sometimes people do better on Botox. Many of you have heard that Botox has been approved for chronic migraine if you've failed 3 classes of preventative medications. And if you're not doing well on drugs like Imitrex, Maxalt, Zomig, Relpax, the acute therapies. So Botox has been approved for use. The advantage to Botox is that you don't take it by mouth. It's an injection. It probably doesn't have much absorption, and you don't have systemic side effects from it. So I hope that's helped, Rosalie.
Our next question comes from Carrie. Can perimenopause onset migraines be severe enough to present itself as a hemiplegic migraine?
Oh, that's a great question, Carrie. Yeah, it can. The perimenopause can be associated with actually new headaches. It's not very common, but about 2% of women might get new headaches at the time of menopause or perimenopause. And the headaches can be different. They can be different. For example, you're talking about a headache with aura hemiplegia, for example. It's rare, but it's certainly, we all see it. The problem with that is you just can't say, oh, that's due to your headaches. I think if this was something that was brand new for you, particularly if you were on oral contraceptives or hormone replacement, you really have to be seen by a specialist urgently, because the big thing is that if this is something new and you're in a state of hormonal change, and it depends on other risk factors. Are you a smoker? Do you have a tendency to have high blood sugar, hypertension? You really have to rule out the fact that this could be a TIA, a mini stroke, a transient ischemic attack. So these are things that you would be evaluated by a physician for, and because it doesn't necessarily mean they aren't a migraine, but you don't want to say, oh, that's what it is because I've had migraine. So that's something that would need to be evaluated by a physician. Thank you.
Thanks. Our next question comes from Sarah. Is Maxalt effective for menstrual migraine?
I think most of the triptans are effective for menstrual migraine. The issue about Maxalt specifically is one that can only be answered by you if you're going to use it for your menstrual migraines. I feel that if a drug like Maxalt is going to work for your other migraines, it's probably going to work for your menstrual migraines. However, here's the caveat. If these are more severe, then maybe you need an injectable. Some people are fine with, let's say, Maxalt during the rest of the month, but they might be woken up in the middle of the night with a bad headache. And then for these night headaches, sometimes you'll need to go to the injectable, like Imitrex injection or sumatriptan injection. But Maxalt as a drug to treat your headaches, whether they're at other times of the month or day before or the day of, should work. And there's only one way to find out, and that's give it a try. But if you have recurrence, if your headaches comes back too quickly, if it doesn't work the first time, you may need something like an injection. So I think that's something you'll have to try. But there's no reason it shouldn't. It really depends on you, and it depends on the migraines.
Our next question comes from Carol. What is dopamine, and is there a connection with migraine?
Wow, what a great question. That I wish I had a chalkboard and stuff, because we could talk about that all day. I'm gonna do a mini lecture. It'll be 1 minute, but there's 3 neurotransmitters in the brain that we're used to thinking about with migraine, and they're transmitters for a lot of things, for most things in the brain. Dopamine is one of them. Norepinephrine is the second, and serotonin is the third. So by manipulating these in different ways, we try to help people who have migraine. For example, it's thought that serotonin is the big player in headache because, for example, drugs like Imitrex and Maxalt and Zomig and Relpax, they have structures very similar to serotonin, and you take them and your headaches can be greatly improved. But another major player, and this was noted years ago, is dopamine. Now, dopamine as a transmitter is really important in things like nausea, vomiting, and anti-dopamine drugs are very good drugs for treating nausea. For example, if any of you have had drugs prescribed for nausea, you may recognize the words compazine, thorazine, Reglan, Phenergan. These drugs are dopamine antagonists. They block dopamine and therefore block the nausea and vomiting. Now, so they're, and these drugs, even more importantly, the drugs that are used in nausea many times treat the migraine itself. So based on the fact that people can get compazine in an emergency room, IV, and their nausea goes away, but their headache goes away as well, we think that dopamine is an important player in migraine, and dopamine antagonists are very important drugs for helping migraine relief. That's a great question. Thanks, Carol.
Our next question comes from Laura. I'm 63, postmenopausal, and I've had a hysterectomy 25 years ago. My fallopian tubes were not removed. When I try to stop Premarin, I immediately get very bad migraines. This is the only reason I continue to take estrogen. I never had night sweats or hot flashes during menopause, although I had plenty of mood swings. Can you please name some soy-based estrogens to use?
Yeah, Laura, you have a pretty common problem that a lot of people have who got on hormone replacement therapy, and that is if you try to go off hormone replacement therapy, you have symptoms of menopause again, basically, and that's not surprising because you're sort of artificially keeping your estrogens up. So if you quit taking your artificial estrogens, they're going to fall again. And of course, any falls are related to having headaches. And so it's like Premarin's putting off having menopause. Then your menopausal symptoms aren't going to be as long or as bad, but you're still going to go through that. And that's not particular to Premarin. I think if women are even on soy-based higher dose hormone replacements, you still are going to be expected to have some sort of transition when you stop taking the artificial ones. The fact that you had a hysterectomy but your ovaries were left in really means that you went through menopause not when you had a hysterectomy but later on because you still had working ovaries. I assume that if they left your fallopian tubes in. So you had to go through menopause probably around 50 or your early 50s. So if you discontinued Premarin, you'd have a tough time for a while, but then you would be probably headache-free and symptom-free. If you wanted to switch from Premarin to a more soy-based product, there's a lot of things. There's patches, there's pills, things like Vivel patch, for example. You don't need, because you don't have a uterus, you don't need progesterone, so anything that would be only estrogen would be fine. Things like estrase, estradiol, the Vivel patch. You also could do, like many women are interested in bioidentical hormones, and these are usually compounded by naturopaths or compounding pharmacies. Those are low dose. They're also natural products. So, so again, if you go from a higher estrogen to a lower estrogen, or you stop, you'll have a little bit of a difficult time. And it's a change because hormones are very powerful, as you know, but it's something that you have to face. A lot of women now, of course, are choosing not to go on hormone replacement therapy, but sometimes if you have a complete hysterectomy, that is ovaries and uterus out at a younger age, you pretty much have to be on hormone replacement therapy or you could start bone loss. So it kind of depends on, what kind of hysterectomy you have and how old you are when you have it. But thank you. That was a great question, Laura.
Our next question comes from Karen. At 40, I started menstrual headaches, which progressed 1 to 6 days at my period over several years. The headaches became unpredictable and at age 50 became daily and have remained daily even though I'm now 2 years post-menopause. I'm currently using Botox. Is there any hope for me?
Oh, hi, Karen. Boy, there's a lot of questions. I think if I had you sitting in front of me that I'd like to ask. I think you've pointed out a really good point, and that is that your association with your menstrual period can really start at any age. For some women, you notice it in your teenage years. For others, it might not even be there until your 30s or your 40s. But the fact that you started seeing that association in your 40s may mean that, and it's difficult to know, but it could be that in your 40s you tend to start perimenopause, and so maybe that change, that sensitivity really didn't happen until then, and it just kept getting worse and worse. But the fact that you had that association then makes it a little bit surprising that when you were done at age 50 that you not only you didn't get better, you got worse. So a lot of questions would come up. The most important ones would have to be with medication use. A lot of people would want to know if you were taking, daily analgesics. A lot of folks will take daily Excedrin, daily Tylenol, daily aspirin, daily Fioricet, daily, whatever an analgesic would be. And if you use them more than about 10 to 15 days a month, you can get into trouble and have daily headaches. If you and your doctor have gone through all your medicines and you find that medication overuse is not an issue, then I think your headaches becoming daily headaches are going to be difficult to treat. Again, we're getting back to 4 to 5% of the population that has daily or near daily headaches, and it's really a tough thing, and I feel badly for patients that we can't help. We usually can. I think Botox has been a surprisingly effective drug for many people who have daily or near daily headaches. Sometimes you need Botox in combination with other preventative oral therapies, but again, I can't really speak to your particular situation because I don't have the knowledge of things you've tried and other things that you might be taking. But I will answer the last question, is there hope for me? Yes, there is hope for you. And sometimes when you think, it's just not fair, you've been hit with daily headaches, sometimes they can just stop as fast as they came on, too. So good luck with that, Karen.
Thank you. Our next question comes from Pam. She's had a hysterectomy in 2005, soon after she developed chronic migraines and fibromyalgia. She is currently on hormone replacement therapy, testosterone, and Vivel-Dot. She takes Frova, gets Botox injections, but she still has migraines almost daily. Do you have any suggestions on something she should be doing or changing?
I don't know, Pam. What I don't know is how old you are. If you're, let me kind of take a guess here. If you're at if you were premenopausal when you had your hysterectomy, if you were younger and that's why you're on hormone replacement, sometimes having a hysterectomy done early has been associated with worsening headaches, not better headaches. It's difficult research because it's messy when you try to put the hormone replacement thing into it. I suspect because you have chronic migraines that maybe they tried to take you off your hormone replacement therapy or change it, and that would be something that would be very important. Hormone replacement therapy, testosterone, Vivel, I mean, these all are potent hormones and sometimes can cause chronic migraine. So if that's been changed and you still have it, then you have to kind of look at other routes. But if they haven't been manipulated, then that's very, very important. If you had your hysterectomy when you were about menopausal age or postmenopausal age, then obviously we're dealing with something completely different. And you probably wouldn't be on all these. Most people would tend to take you off of them, so I assume you had it done at a younger age. Frova, I don't know if Frova is helping you. It certainly has a long action, but it's not a very potent drug if you stack it up to some of the other migraine-specific drugs. The problem if you have chronic migraine is that you can't take Frova all the time. You can't take Imitrex all the time. You can't take Maxalt all the time. So you're really stuck with your preventative therapies. And because you're on Botox, I assume that you've tried drugs like Topamax and Depakote and Nadolol or Propranolol. You've tried all the different classes. Sometimes you have to go back and do that with the Botox, just maybe oral therapies, pharmacologic therapies, and non-pharmacologic therapies as well. So besides doing Botox and maybe Topamax, you might find that acupuncture or biofeedback is also a good addition. Because you tell me that you have fibromyalgia, it seems like your pain receptors, basically, whether it's body pain, somatic pain, or headache pain, has really been upregulated with the hysterectomy, and then a multidisciplinary approach is something that you're going to have. Fibromyalgia is very difficult to treat too. There's some drugs like Lyrica out there and Savella and Cymbalta that might help, but the only thing that's really ever been shown to help with fibromyalgia is really exercise, and that's really hard because the big hump of getting out there and exercising when you're in pain is not an easy thing to do. So good luck with that, Pam.
Just an update on Pam. She was 47 when she had the complete hysterectomy, and she's now 54. And it looks like her testosterone that she takes is compounded cream, 30 milligrams daily, and Vivel is 0.05 milligrams.
Yeah. Well, that's a tough age. I mean, it would have been hard to decide at 47 whether you should go on hormone replacement therapies or not. You could have played it either way, and certainly now you don't need to do it at 54. But again, as we heard before, sometimes getting off of these is a little bit tough as well. But if you haven't done it, that certainly would be something to try. As your doctor may have told you, the longer you have daily headaches, the tougher it is to sort of revert them. But sometimes people stop. Sometimes chronic migraine becomes episodic migraine again. So it's sort of this waxing and waning character to it. But that's something you're really going to have to work on with your a headache specialist. There's a lot of different things you can try there, and again, I'm not privy to everything that you've already tried, but you may need a multidisciplinary approach for this, and if you haven't tried to change that estrogen and testosterone, you've got to do that.
Well, I'd like to thank everyone for their questions, and Dr. Lucas, thank you again for joining us, and we do apologize for the technical difficulties there. I hope everyone has a nice holiday, a nice evening, and thank you for joining us.
Yeah, thank you very much, everyone, for calling in with these wonderful questions, and I hope I've learned from you. I always do, and I hope we've learned from each other. Thanks again.